Welcome to the NHEF Virtual Summit, Living in a Post-Pandemic World, What Medicine Has Learned in the Last Year, a joint continuing medical education program brought to you by the North American Thrombosis Forum and Ciencias CME. Before we dive into this evening's program, here are the relevant financial disclosures for the course planners and content reviewers. At the end of this program, participants should be able to recall how mRNA technology used to develop vaccines for COVID-19 can be leveraged in cardiovascular medicine, explain how the link between inflammation and thrombosis that has characterized COVID-19 has implications for other aspects of medicine, describe long COVID syndrome and how medicine will handle this complication of COVID-19, summarize trends in cardiovascular care utilization during the COVID-19 pandemic and implications for future burden of disease, and recognize healthcare disparities exposed by COVID-19 and how medicine needs to make changes for the health of all of our communities.
Good evening. I'm Dr. Sam Goldhaber, President of NATF. It gives me great pleasure to introduce this evening for our NATF Summit. The summit is probably the single biggest event we have in terms of educational activity for healthcare providers, patients, and families. And this evening, we're going to focus on a topic that's been on our minds since early 2020, and that is COVID and all the implications of this COVID pandemic. At this point, more than 700,000 Americans have died of COVID, and many feel that's an underestimate. In January of this year, we had the huge death rate of more than 3,000 Americans each day. And that's like a 9/11 catastrophe each day for the month of January. Now we're still seeing the ravages of this viral illness. The death rate remains at about 1,500 per day, but we are looking toward an optimistic future as our vaccination rates increase, our booster shots take effect, we start to develop a herd immunity, and we get ahead of the anti-vaxxers with better education and in some cases with mandates for vaccination. Now, we've learned a lot during COVID. We learned that mRNA technology can do wondrous things beyond the imagination in a very short period of time. It was only 48 hours after the Chinese posted the structure of the COVID-19 virus that Moderna was able to put together a first draft of its vaccine. And we've also become very aware now of the healthcare disparities because COVID thrives in a crowded household. COVID thrives where there is poverty. And the healthcare disparities that we've been aware of in the past have really come to the forefront. How do we take care of individuals and prevent them from getting the virus if they are crowding many family members into a very small apartment? What do we do if they're homeless? How do we handle not only the prison population, but those who work as prison guards in a prison? These are just some of the social issues that have come up over time. And because we are NATF, we have taken special interest in the relationship between COVID and its ability to cause thrombosis, pulmonary embolism, DVT, myocardial infarction. These rates are very high in the intensive care units. And also, we have to think of the other illnesses that COVID can cause, the non-fatal, but really quality of life degrading problems of loss of smell, loss of taste, long hauler syndrome with a chronic fatigue that really puts a damper on quality of life. So this evening, we are very fortunate to have put together a wide array of experts to speak on a wide array of COVID-related topics. And I think this will generate a lot of discussion and food for thought. Thank you very much.
Now I'd like to welcome Dr. Catherine Stevenson. Dr. Stevenson's a physician scientist in the Center for Virology and Vaccine Research and the Division of Infectious Diseases at Beth Israel Deaconess Medical Center. She has expertise in conducting phase 1 clinical trials, testing novel immunologic interventions for HIV and emerging infections like SARS-CoV-2 and Zika. During the COVID-19 pandemic, she was the site principal investigator for the first in-human trial of the Johnson & Johnson Janssen COVID-19 vaccine, as well as the phase 3 efficacy trials for remdesivir, the Novavax vaccine, and a number of antibody therapies. She's currently the protocol co-chair for CoVPN 3006, the largest federally funded study to test whether the Moderna COVID-19 vaccine can block SARS-CoV-2 transmission. Please welcome Dr. Stevenson, who'll be talking to us about riding the wave of mRNA vaccine technology applications in cardiovascular medicine.
Hello, everyone. Today I'm going to be talking about mRNA vaccine technology, what we've learned from the COVID-19 vaccines, and potential applications in cardiovascular medicine. So I'm a physician scientist. I do a lot of vaccine research as well as immunotherapy studies, and these are funded by various different companies, but I personally don't have any financial interest in those companies. So today I'm going to be talking about first reviewing mRNA technology, going through how they work, and doing a brief summary of mRNA vaccines, which we know well for COVID, and then get into a little more detail, going through potential uses of mRNA therapeutics in cardiovascular medicine, and then ending on a bit of a review and maybe a cautionary tale about mRNA and the risk of myocarditis. mRNA is typically packaged these days for delivery in a lipid nanoparticle. This image is showing the LNP, as we would say, for mRNA 1273, which is the Moderna vaccine. And what happens is that this lipid nanoparticle is taken up into the cytosol of the cell, and the mRNA moves through this pathway until you have production of these viral spike proteins. In this case, it's the spike protein from SARS-CoV-2, but it could be any protein of interest, which is then expressed on the surface of the cell. Now, in the case of vaccines, the whole point is to generate antibodies. So the immune system sees these proteins and develops this full immune response. This is the LNP, the lipid nanoparticle, and how it's structured. The mRNA is in the center of what you can consider like a drop of oil. And then on the outside are phospholipids and cholesterol and different things, and sometimes some proprietary technology there. mRNA was discovered in the 1960s, messenger RNA. And there was the first attempts at really clinical application of this happened about 20 years ago. And in those first trials, what people were doing was just injecting naked RNA, meaning just on its own. And that's a very unstable product. It degrades very easily, number one. And then number two, it was observed that there was a big inflammatory reaction that was occurring in a bunch of patients. So it was coming with massive side effects. And around the same time, people started to figure out that the body actually can recognize RNA, particularly double-stranded RNA, as soon as it sees it. So it's not something it has to learn how to do. It's part of our innate immune system, and it's because the body really sees that as potentially a virus. And this triggers a real dangerous signal to the body. And then there's a whole cascade of inflammatory symptoms that follow. So one of the biggest advances in this technology occurred about 2005 with Dr. Carrico and her paper showing that if you could modify some of the nucleotides of this mRNA, sometimes called mod mRNA, then you could suppress this danger signal. And this was really a big breakthrough. And in the last 15 years or so, that's what really made this technology take off, as did packaging it into these lipid nanoparticles. And this is also when biotech got a little interested and you started to see startups. And there were a bunch of these phase 1, phase 2 trials in a lot of spaces, particularly oncology. But it really stayed in the phase 1 and phase 2, maybe 1,000 or so people until, of course, 2019, really going in, obviously 2020, when the Moderna vaccine and the Pfizer vaccine were developed for COVID-19. So since that time, starting January 2021, 6 billion COVID-19 doses, most of which are mRNA, have been administered globally over a 10-month period. And I always show this figure just to emphasize that these have been delivered almost entirely in upper middle income and high income countries. I don't really need to point this out, or maybe I do. These vaccines are incredibly effective. They remain incredibly effective, even in the setting of waning immunity and the Delta variant. This is a figure that has data all the way through September 2021, showing this giant difference in the incidence of COVID-19 between those who are unvaccinated and those who've really received like any vaccine. So we've been talking about vaccines, but when we're talking about application to cardiovascular medicine, we're really talking about therapeutics, but there are advantages of mRNA as well for therapeutics. So the first one is that it has the ability to act on targets that are hard to reach by traditional small molecule therapy or proteins, so-called undruggable targets. And they are biologically active in both dividing and non-dividing cells. But importantly, does not actually require entering the cell nucleus. So you don't have to worry about integration into DNA or potential oncogenic potential. mRNA is degraded very quickly. It's very rapid and cost effective to develop and has the ability to rapidly alter the sequence of the mRNA construct. Now that's really helpful for vaccines, but it's actually really helpful too if you want to personalize your mRNA to an individual patient. And there's a great variety of potential RNA applications to cardiovascular medicine. And I have to say, some of this is just like pure speculation, but some of it is actually in biotech development pathways. So, mRNA is there to produce a protein. So that protein can do a number of different things. It can compensate for a defective protein. It can be a totally new therapeutic protein. It could be a protein that alters cell signaling in some manner that can make cardiac stem cells that could be used for regeneration. It could express an enzyme that corrects a defective gene or silences a defective gene. And this has been useful for familial hypercholesterolemia, for example. But really the majority of, certainly where the biotech industry is interested, is how it can be used in the setting of ischemic injury. So this is a figure that's just kind of showing, all right, you have a heart, right? Something happens, you have a myocardial infarction, and you have a big clot, and you inject this mRNA therapy, and we'll talk about how that could be done, that will prevent remodeling of the heart. So we'll go forward so that we're trying to prevent heart failure. And you can do this by maybe inducing regeneration of those cells, proliferation of the cells, or maybe just protecting tissue from being remodeled. And so, like I said, really the focus is on myocardial infarction, MIs. And the key directions are to reawaken cardiomyocyte proliferation so that more cells can come in and regrow. Deliver enzymes that can prevent cell death. so that you can keep them from dying. That's pretty simple. And then another pathway is to regenerate or encourage blood vessels to come in to increase blood flow and to support these cardiomyocytes to prevent them from dying. And the most prominent, actually the first application of this ever in humans came in 2019 in the first in-human study of intradermal delivery of mRNA that encoded for vascular endothelial growth factor A. The study design for this study, and I'm gonna go through a couple slides because it's actually the only one that is really advanced this technology into the clinic. But it's a randomized, double-blind, placebo-controlled phase 1 study. They used mRNA that encoded for, as I mentioned, vascular endothelial growth factor A, which encourages blood flow and the growth of blood vessels. And they tested this in men who had type 2 diabetes that were aged 41 to 65. And their thinking there was they were kind of looking at people who might be like future vascular paths with vascular disease. And what they did is they did these intradermal injections of the mRNA on the volar surface of the forearm. And what they were looking were really some proof of concept stuff. So number one, they wanted to detect, to see if they could measure this protein, VEGF-A, in the site of injection, because number one is just to prove, like, does this stuff even work to make the protein that you want? And then the next thing they did was to look at a more functional thing, which is the local blood flow to the skin as measured by Doppler imaging. So here's a figure representing the VEGF-A concentrations in the skin after injection. So they were happy to see that there was detectable protein at the site of the injection in a dose-dependent manner. So the more mRNA you gave, the more protein that was detected. And this is over a 24-hour period. And then in addition, they were happy to see that it was transient. This is something they intended, which is to have essentially like a pulse of protein. And the idea is that you don't necessarily want to have like forever production of a protein. You really want to focus on this acute injury, helping that heal that injury and then being done. And mRNA is nice that way because it's so quickly degraded. So then they looked at the increased blood flow to these injection sites, and they were happy to see that downstream at day 7, in fact, there was increased blood flow as measured by this Doppler, and it was also in a dose-dependent manner, and it was mostly resolved and done with by day 14. This is a representative picture of one of their participants showing this increased blood flow. So this is, in fact, the forearm that they're showing. It's not actually like a contrast image, but it's similar. And just focus on the middle figure, which is day 7 and that second ring. And you can see this kind of blush of increased blood flow to that spot that by day 14 was gone. So it's really like a targeted infusion of blood flow to a site of, potentially to a site of injury. But there are challenges to mRNA technology. So what was beneficial for that prior application may be a problem. So for example, the short cytoplasmic half-life. So if you want to have a little bit of a longer exposure to your drug, this may require repeated dosing, and that may come with more side effects. There could be antigenicity of that transcribed mRNA. So some people may be more sensitive to it, akin to the, maybe that danger signal is still around a little bit. Another thing is that there's no inherent tissue targeting of that lipid nanoparticle, meaning that if you give an injection in the arm, it's not necessarily going to find its way to the heart, which is your target tissue. And what that means is that may require intracardiac injection to actually get the mRNA to the tissue that you want. And this Moderna trial of that VEGF-A, that's actually where they're going. They're going into a phase 2 trial where they're going to be doing epicardial injections. But this can cause stress and local injury to tissue all by itself. And it also makes it much more challenging to give a consistent dose across the myocardium and also between patients. And if you have like a really big heart, this may require a big, hefty dose, much higher dose than what we're used to giving for the vaccines, which are very, very tiny doses. But there's future progress in this. One is to create these LNP systems that actually target activated endothelium, like the type that you would find in an atherosclerotic plaque. So what you can do is you can put in that lipid surface there, you can pop in different things that might, cause a tissue tropism that you'd like. The other thing you can do is kind of give up on that really focused target of tissue and go towards something upstream of that. So either going to the bone marrow or the liver, which is very easy. That's just an IV infusion that elicits a response that has a downstream effect for the heart. So I want to end with a few slides about talking about some interesting observations. So we've seen that there are myocardial side effects that are associated with COVID-19 vaccination. There are multiple safety surveillance systems, multiple different countries that have shown that there is definitely a risk of myopericarditis following mRNA. This risk has been seen mostly in adolescents and young adults, men way more than women, and following dose 2. It tends to cluster within a few days of vaccination, and generally the cases are mild and resolve. This is a figure from the CDC meeting on this, their vaccine safety meeting, actually just about a week or so ago, where they presented data that they had analyzed very carefully from VAERS, which is the Vaccine Adverse Event Reporting System. So these are rates above the background incidence. And here I'm just showing the rates in males, which are because they're so much higher than what we're seeing in females for Pfizer and Moderna. And the rates are really much higher, clearly, in dose 2. And then also in this age cohort. So from 16 to 24 is really when you see this like escalation in the rates. Clearly, when you're talking about millions of doses, this is a very rare side effect, but it's present. Whether this is relevant for cardiovascular applications, considering it's not in older adults, remains to be seen. But I think that it's a little bit mysterious why this is happening. What were the outcomes of these cases? So in order to analyze this, VAERS is a system where people can report almost anything. So the CDC took some time to actually dig into these cases and apply strict case definitions. And when they did that, they had 877 cases. Now, almost all of them were hospitalized, which sounds alarming, but I think it's a reporting bias. Probably those that are hospitalized are the ones that the physician actually enters this into the system. 77% of those that were hospitalized were known to have completely recovered from myocarditis. So that's why you hear that this is generally clinically mild and resolves, because that's true, 77%. At the time of this analysis, 19 were still hospitalized, and there were actually 5 in the intensive care unit. Outside of the US, there have been deaths as well reported from this. So it's not universally mild. There are some outliers. Take into consideration the millions of doses, it's extremely rare, but it does happen. There was some question for a while about whether this is really myocarditis or some sort of cluster of symptoms that mimic this. But here's some histology that shows it is myocarditis. So the first one is from a biopsy that showed multifocal cardiomyocyte damage, and then an autopsy, which was interesting because it showed an inflammatory infiltrate, but also particularly noted eosinophils, and maybe that's a clue towards some sort of mechanism here. Speaking of mechanisms, there's nothing known. I'll just be honest with you, no one has figured this out yet. We just observed it, so there's a lot of work to be done, but there are some potential mechanisms that have been speculated. So if you recall, for example, that danger signal that I talked about, maybe there's a genetic predisposition where some people just continue to overreact to seeing this RNA. The lipid nanoparticle itself, even with nothing in it, can cause a lot of inflammation. Many of us who've gotten these vaccines experienced that firsthand. And sometimes that can generate a kind of diffuse autoantibody, like lupus-y kind of syndrome. And then you can have direct molecular mimicry. So maybe we don't know. Maybe there's a protein in one of our cardiomyocytes that looks exactly like the spike protein. Now you're creating antibodies to both. Or this is just in the spectrum of allergic reactions, right? Like a delayed hypersensitivity reaction. And that's really interesting considering that that path showed some eosinophils. In regard to why men more than women, I mean, when you see that, you have to go to think that there's some sex hormone difference. Maybe estrogen is protective, this is just speculation. So where does that leave us with the path forward for mRNA and cardiovascular medicine? mRNA COVID vaccines have shown safety and efficacy really now, billions of people, billions of doses have been administered. And mRNA therapy has similar potential, explosive potential, but really different challenges. Because remember, we've seen for COVID, it's vaccines, but for therapy, it's different. There are many diverse potential applications for cardiovascular medicine, but probably the most promising and concrete right now is the Moderna product of delivering mRNA that expresses VEGF-A. And with the goal of increasing blood flow to areas of acute myocardial injury. Lastly, I'll just say, I think that the technology is here for this. I think that probably we'll develop these LNPs that can target tissues. We can get cool proteins in there, but I think the limiting factor for this may be safety. And I think I say that because it's interesting that we see this side effect with the vaccine, and we just really haven't tested this in a lot of people. So I think that that's something to keep in mind going forward, is that we need to have really good safety surveillance about how well tolerated these mRNA therapeutics are. And with that, I will end. Thank you so much for your time.
Next, I'd like to welcome a friend and colleague, Dr. Peter Libby. He's a cardiovascular medicine specialist at Brigham and Women's Hospital and holds the Mallinckrodt Professorship of Medicine at Harvard Medical School. His areas of clinical expertise include general and preventive cardiology, as well as vascular medicine. And his current major research focus is the role of inflammation in vascular diseases such as atherosclerosis. And he is the ideal person to speak to us on thromboinflammation and COVID-19, lessons in thrombosis for a post-pandemic world.
Hello, it's a real pleasure to participate in the symposium of the NATF. I think I participated in the very first activity of NATF, and it's been wonderful to watch how NATF has grown and serves important needs for both practitioners and for patients and families. So I was assigned to speak about thromboinflammation in COVID-19 and to draw some lessons in thrombosis for a post-pandemic world. That's quite a tall order that I got. These are my competing interests. I do not accept any personal financial reimbursement or payment from pharma or device companies. I am on the board of a biotechnology company that does not market a product. Well, COVID-19, it seems like yesterday, but it seems like forever ago that we learned about this strange pneumonia that was happening in Wuhan, China. And even in that very early Wuhan experience, 40% of the deaths involved the heart. So calling COVID-19 pneumonia was really a misnomer. Very soon it became clear that cardiac injury was quite common in the disease caused by SARS-CoV-2, COVID-19. This is from the New York experience, looking at troponin I levels and stratifying from the lower levels to the higher levels and looking at outcomes. And let's focus here on the red mountain, which is mortality. And you see that the higher degrees of troponin correlated with an increase in death. So certainly this cardiac injury is not at all decorative. It is at least a biomarker and probably causally contributing to the worst outcomes in COVID-19. So somewhere of at least a third of hospitalized patients with COVID-19 have biomarker evidence of myocardial injury. And we can ask ourselves, what are the mechanisms of this myocardial damage? Could it be a direct cytopathic effect, a viral infection of the cardiac myocytes causing a myocarditis? Or could it be due to indirect effects, due to the inflammatory response, which is elicited by the direct infection? So early on in the pandemic, I wrote this commentary in one of our journals where I explained the bookends. On one end, on the left here, fulminant viral myocarditis with myocardial cell infection. And on the other side, type 2 or type 1 myocardial infarction, which I'll explain a little later. And of course, the possibility that one could have a little of each in varying proportions of contributions from direct or secondary myocardial involvement. Now, I'm going to summarize a very confused and controversial literature with my bottom line here in these simple bullets. And that is that there's scant evidence for direct myocardial infection by SARS-CoV-2. Viral antigen or the RNA, the genetic material, seldom co-localize with cardiac myocytes. And in contrast, we see that coronary artery thrombosis, both macro and microvasculature, is very common in COVID-19. This is one of the early autopsy collections, 17 cases. And you see here, let's look at panel D, for example, that the cardiac myocytes look pretty healthy. But look in this intramyocardial microvessel, it's chock-a-block full of inflammatory cells. If you look here in panel A, you'll see an organizing thrombus. And you'll see veins that are filled with leukocytes. So the myocardium looks like the bystander here. Now, we had an opportunity in collaboration with some of my colleagues from Yale to look at some of the Brigham autopsy cases that were collected early on, thanks to fantastic work of Bobby Padera and Rick Mitchell, two of our cardiac pathologists. And we found that there was tremendous evidence for vascular thrombosis in the coronary circulation. We observed extensive micro and macro thrombi in the vast majority of our COVID cohort, and we did not detect SARS-CoV-2 spike or nuclear capsid antigen that indicate active infection or direct infection. And there was scant evidence of multifocal lymphocytic infiltrates that would indicate myocarditis. Here's a shot from our paper, which was actually went online just days before I'm preparing this presentation. And the important thing here is look at the fibrin, which is occluding this small vessel here, the cross striations of the myocardial cells. And if you just look at the aggregated data in panel A, we're looking at the microthrombi, much higher in COVID patients than in controls. And the macrothrombi are also much more prevalent in COVID-19 than in controls. A larger collection with some very experienced and reliable pathologists led by Rino Vermani. They came to similar conclusions. Given its extremely low frequency and unclear therapeutic implications, the authors do not advocate the use of endomyocardial biopsy to diagnose myocarditis in the setting of COVID-19. So although you can find papers that say, oh, we've got direct infection, my read of this literature, which I've tried to follow, really comes down on the side of indirect myocardial injury with thrombosis front and center. Now, we went further with our colleagues from Yale, and were able to find signs of neutrophil polymorphonuclear granulocyte activation in COVID-19. We see, if you look at the graphical representation here in panel A, that neutrophil platelet aggregates are common in COVID-19, and we see neutrophil macrothrombi as well. And we found co-localization with a marker of neutrophil extracellular traps, NETs, which are on the cutting edge of thrombosis research, as this audience knows. We looked at citrullonated histone 3 in red here as a marker of net formation and found co-localization with the neutrophils, the thrombi, and the neutrophil extracellular traps. So I have discounted this direct viral infection and really focus on the indirect effects of COVID-19, primarily thrombosis. Now, how does thrombosis come about? Well, the endothelial surface under normal circumstances is miraculous. It is one of the only surfaces, either natural or synthetic, which can maintain blood in a liquid state during prolonged contact. And it owes that property to a series of tightly regulated properties associated with the surface of the endothelial cell. You see that the normal endothelial cell can release the anti-aggregatory prostanoid, prostaglandin, thrombomodulin, which actually turns low concentrations of thrombin into an anticoagulant, natural forms of heparin on the surface of the cell, and should a stray clot form, we have our endogenous fibrinolytic enzymes, TPA and UPA, that are associated with the surface of the normal endothelium. But the endothelium can show a different face when it becomes activated during inflammation. And it can release an inhibitor of fibrinolysis, plasminogen activator inhibitor. It can express tissue factor, which is the trigger to many thrombi. And it can release von Willebrand factor, which is the glue which holds platelets and fibrin and thrombi together. So what is it that turns the switch on the endothelial cell from these usual homeostatic anti-aggregatory, anticoagulant functions towards prothrombotic and antifibrinolytic functions? Well, we know that those cells can be triggered by signals that we can call pathogen-associated molecular patterns. And a classic example is gram-negative bacterial endotoxin, lipopolysaccharide, or damage-associated molecular patterns. We call them DAMPs, PAMPs and DAMPs. And a classic DAMP is interleukin-1 alpha, a pro-inflammatory cytokine that is a product of injured cells. And they interact with receptors known as toll-like receptors, pattern recognition receptors, for which the Nobel Prize was awarded a few years ago, and activate a number of pro-inflammatory functions, including altering the balance of the endothelial cell surface to favor thrombosis and accumulation of thrombi. Now, I've actually been interested in this for a long time. You'll see here, this publication was from 1989 in this crude diagram I drew with the early version of Mac Paint. And we make the point that when we have a PAMP, a gram-negative endotoxin, that it can elicit pro-inflammatory cytokines such as interleukin-1 or tumor necrosis factor. This is 1989, note, and that can tip this teeter-totter towards the procoagulant, antifibrinolytic, and prothrombotic set of functions of the endothelial surface. And in COVID-19, you see this operating in great force from head to toe. Large arteries with the strokes that had happened in young people as a presenting symptoms without other risk factors, microvessels in the lung, kidney, heart, and of course the famous COVID toes, reflecting microvascular thrombosis and spasm, and in the systemic veins, the mainstay of NATF, venous thromboembolism. So what's in common between all these different types of vessels? They're all lined with those precious endothelial cells. And I put this figure in for Doctors Goldhaber and Piazza to show the deep venous thrombosis in a patient that's affected with SARS-CoV-2 and the pulmonary embolism. And so you have double trouble in the lung in COVID-19. You have a rip-roaring pneumonitis, but you also have diathesis towards thromboembolic disease causing these pleural-based pulmonary infarcts. Microscopic study of the lungs in patients who have succumbed to COVID-19 show microthrombi, as we saw in the myocardium a moment ago, in the alveolar septi in the lungs. And we see that there's a leaky, the barrier function of the endothelium has been impaired. There are erythrocytes where they shouldn't be, extravasated into the alveolar space. And look at this network of fibrin. So we see endothelial dysfunction up close and personal as part of the lung damage in COVID-19. Now, as I say, I've been interested in this intersection between infection and inflammation and vascular disease for a long time. I was asked by the National Heart, Lung, and Blood Institute way back in the 1990s to chair a panel on the roles of infectious agents in atherosclerosis and to take the lead in publishing the proceedings of that symposium. And we've had follow-on meetings, and most recently, back in 2018, well before we had imagined SARS-CoV-2, put together this piece published in JACC on inflammation, immunity, and infection in atherothrombosis. And one of the points that we made is that when we have preformed plaques lying in wait, as many people of a certain age may harbor in their coronary tree, we can have echoes of distant inflammation from various sources, as you see here. And I put this red box on top of what we published in 1918, bronchitis, influenza, pneumonia. So we get release of cytokines, we activate leukocytes, we have release of those PAMPs and DAMPs, and they can travel to the plaque, activate the inflammatory cells that are lying in wait, quiescent, and push the atheroma through a round of complication. So when we have a severe infection, such as with SARS-CoV-2, it's a perfect storm for myocardial injury. We have increased oxygen demand due to tachycardia and fever. We have reduced supply due to hypotension and hypoxemia, and that sets the stage for myocardial ischemia, or a demand type of myocardial infarction or acute coronary syndrome. So the mechanisms of the cardiovascular complications during acute infections include that imbalance in supply and demand of oxygen, the accelerated atherosclerosis with that echo due to PAMPs and DAMPs that are released from a distant inflammatory site, the thrombotic diathesis that we discussed in detail, and I don't have time to go into the vasomotor dysfunction of activated endothelial cells, which can certainly contribute to vasoplegia and some of the complications of severe infection or sepsis, viral or bacterial. So I was asked to think about what we need to learn for the future, and we need to be prepared to see a wave of post-COVID syndromes, some of which may be prolonged. We won't know until we study this better. We all have heard of long COVID, and it's going to take us several years to sort out what to do with long COVID, how to diagnose this, and how to treat it. So I was asked to come up with some lessons for the post-pandemic world. And I'm going to get on my soapbox and give you my little take on this. So if you go on to clinicaltrials.gov, there are almost 7,000 studies. Now, some of you might think that that's a good thing because there's all of this activity, but actually, I think that it is too many studies. Confusion and uncertainty have reigned. And I'd like to go through a brief case study of targeting a pro-inflammatory cytokine that I've studied for many years, interleukin-6. Now, interleukin-6 has been trialed in many different investigations, different strategies for neutralizing interleukin-6, including the monoclonal antibody tocilizumab, which is approved and which has been studied in many clinical investigations. Now, let me take you through this nice table from JAMA from late 2020. This summarizes some studies with neutralization of interleukin-6, threshold for efficacy not met, 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 threshold for efficacy met. Okay, so here we have a bunch of studies and we don't know what to think. And the editorialist very sagely said that we should consider the use of tocilizumab if and only if more compelling data emerges from randomized clinical trials. Well, the CDC, NIH, made a recommendation back in March saying that, well, there are some people who are pretty sick that you should consider giving tocilizumab to. And then The August New England Journal of Medicine had 2 back-to-back articles in April of this year, 2021. This study looks great. Hospital mortality of 27% with treatment versus 36%. So thumbs up, great. But the next article said mortality was 20% in the tocilizumab group, 20% in the control group, neutral. Okay, so what is the public to think when we doctors can't get our act together to come up with a consistent story? The editor-in-chief of the New England Journal, Eric Rubin, took the lead in this editorial of these 2 papers. For now, we are left with evidence of benefit from interleukin-6 inhibitors, at least under some circumstances, but how to best use them remains unclear. And here's one of the latest salvos from July of 21, a meta-analysis that shows, well, there's a scattergram, but on the bottom line here, we do see a statistically significant benefit of giving tocilizumab. So the FDA in June authorized tocilizumab for treatment of COVID-19. But what is the public to think when we have all of this uncertainty within the specialists? So I agree with my buddy Rob Califf, who was briefly the commissioner of FDA under Obama. And he said that this is a teachable moment for improving our research infrastructure and relevance. Instead of having almost 7,000 studies, what about if we had 700 studies that were all well-controlled, double-blind placebo trials? What about if we had 70 studies that were large, sufficiently powered, and rigorously designed and executed, not observational, this or that, not anecdotal, thus or such, but actually trying to apply what we know of clinical science. For the next pandemic, we need to be better organized as a community to try to confront marshaling our resources in a conjoined way to answer the questions in a definitive manner that won't sow confusion among the public, which we're confronting now in the face of vaccine resistance. So after COVID, much is going to change in medicine and beyond. We will learn and teach remotely more than we did beforehand, and we'll find the just mean as the needle comes towards the median. And we may provide more of our care for patients remotely. We don't have to bring patients into the medical center for a blood pressure check with wearables, with home devices, with the internet. We're going to be able to provide some of our care for patients, never replacing the face-to-face, but using remote visits. So the COVID crisis is spurring innovation and hastening change. So let's conclude with a positive spin, is that we have a lot to learn. We need to prepare ourselves better to confront the next pandemic. And we must never forget a primal role for thrombosis in the complications of COVID-19. So my parting wish for the entire audience is to stay safe and stay well. Thank you so much.
Now I'd like to welcome Dr. Kristen England, who's the Vice Chair of Infectious Disease at the Cleveland Clinic and has been at the clinic for nearly 20 years. In response to this prolonged COVID-19 pandemic, she's worked with a team of specialists to develop the Recover Center of Excellence, opening to its first patients in February 2021 and helping patients and families who've been touched by the COVID-19 pandemic to find a pathway forward. Please welcome Kristen England, who will be speaking about long COVID syndrome, a pandemic after the pandemic.
Thank you for inviting me to come and speak at your conference. We're going to be talking for the next 20 minutes or so on the entity called long COVID. You'll hear patients referring to it as long COVID, but when you look at papers or the NIH, they refer to it as the post-acute sequelae of SARS-CoV-2 or PASC. I refer to it, though, as the pandemic after the pandemic. I have no financial disclosures, and I will not be discussing any non-FDA approved indications. So what we're going to talk about is just understanding the epidemiology of long COVID. Who does this affect? Recognizing the symptoms, understanding potential causes for persisting symptoms, although understanding that we have so much to learn on this, appreciating specific challenges for certain populations, and then lastly, learning about some of the resources for sending your patients who are going to need continued help. So early on in the pandemic, only, say 6 months into our COVID experience, people started noticing that patients were not fully recovering even after their acute hospitalization. So Huang, coming out of China in January of 2021, published information about their first 6 months with patients suffering from this new entity and found that 76% of all patients who had been hospitalized, and they were looking at over 1,700, had at least one persistent symptom. Now, these were older folks and predominantly men at this point, but 1 in 5 patients who had not required supplemental oxygen still had decreased lung function after that first 6-month time period. In the United Kingdom, they found that 66% of young, low-risk patients had signs of damage in 1 or more organs even 4 months after their COVID diagnosis. And these weren't people that had been hospitalized during their initial disease. Only 18% of them had been hospitalized. So now we're seeing people who weren't really sick having these persistent symptoms. We find out throughout the rest of the world, in France and the Faroe Islands and in Switzerland, again, about 35 to 50% of patients had these symptoms that were persisting, and actually almost 3/4 of them reported new symptoms coming on during that period after the acute disease. And the Ohio State University even looked at some competitive athletes who'd had very mild symptoms, if any symptoms at all, and they found that there was a 15% incidence of myocarditis in these young, healthy athletes. So what symptoms are we talking about? Well, if you look on the right-hand side, you can see that Carfi et al. Published a lot of the initial data on the acute COVID-19 symptoms, but then also how those compared with the post-COVID-19 symptoms. Fatigue is predominantly seen in both of these entities, but dyspnea persists, chest pain, cough, the lack of sense of smell can certainly still persist, and you can see the rest of them in decreasing percentages. But there's a lot of symptoms that these patients can have, and a variety of symptoms. On the left-hand side, I've listed out some of the more prominent ones that are also being noted that weren't initially seen by Carfi, with difficulty with thinking and concentration. You'll hear this often referred to as brain fog. Fair amount of depression is being seen in patients, and then we're finding some dizziness and heart palpitations as well, and insomnia. So this seems to be affecting all organ systems, and why is that? Well, we know that the SARS-CoV-2 virus uses the ACE2 receptors in order to be able to enter into our cells. And as you can see, there's ACE2 expression on virtually every organ system in the body. So specifically, let's talk about a couple of the organ systems. So the cardiac manifestations of long COVID, we've heard described already, myocarditis, but patients can have pericarditis, arrhythmias, and very commonly complain of this persistent chest pain. So when you understand that the SARS-CoV-2 binds to these ACE2 receptors to be able to gain entry, that blocks the receptor's ability to maintain appropriate vascular permeability. So as a result, the blood vessels get more permeable and fluid starts to flow out into that myocardial interstitial space, taking along with it also some of the inflammatory markers. So you can get direct viral damage, which leads to scarring. You can get inflammation that can lead to fibrosis, and then certainly we can get blood clots. And all of that can cause damage to the heart muscle. Patients will also present with dizziness, especially upon going from sitting to standing. That's called postural orthostatic tachycardia syndrome, or POTS. So when patients have had an extended time at bed rest during their COVID illness, recovery can often lead to postural hypotension. There's also vasculitis that we see during COVID-19. That can potentially lead to baroreceptor damage, and that can result in autonomic dysregulation. There's an increase in cytokines, and that can also cause damage to the autonomic nervous system. POTS can lead people to fall, and that fall can result in syncope. And people who fall tend to have a fear of falling, so that's going to keep them less likely to have to get up and try to be more active. That's going to lead to a vicious cycle of all of this, and their inability to really be able to recover fully. The GI manifestations of long COVID, you get inflammation within the gut. There are ACE2 receptors there too. You get a leaky gut syndrome that leads to a dysbiosis. There's immotility because of the autonomic dysregulation. So patients present with diarrhea, with dyspepsia, constipation, and just abdominal pain. The pulmonary symptoms of long COVID, and this can even be separate from the initial COVID pneumonia that you see. But many long COVID patients have symptoms of lung damage and have breathlessness, coughing, and a limited ability to exercise. If they have abnormalities on their pulmonary function tests, most likely we're going to see the DLCO being decreased, so the diffusion capacity. COVID-19 can cause damage directly from the viral effects, but it's also the inflammation that persists within the lungs afterwards. And in very severe cases, interstitial lung disease develops, and that's going to be permanent damage. Neurologic findings in long COVID are described as the brain fog, as anosmia, so the lack of sense of smell, headaches, neuropathies, myalgias, insomnias, and a wide variety of behavioral health diagnoses. So the prevalence doesn't differ whether the patients were hospitalized or not, with the exception of anxiety. We see anxiety popping up much more in patients who had been hospitalized, and especially if they were in the intensive care unit. PTSD is also something that we can see, but it is also seen more commonly in those who were hospitalized. So why do we get these brain findings? Well, an autopsy of 19 brains of patients with both acute and long COVID showed multifocal areas of damage that's usually associated with strokes and neuroinflammatory diseases. This study by Lee did not find evidence for direct viral infection at that point, but it seemed like it was much more of a microvascular injury. So when we talk again about the mechanisms of neurologic damage, so it's postulated that the virus can break down the blood-brain barrier, especially through the olfactory mucosa, because having anosmia or the lack of sense of smell is such a prominent feature for this disease. It can also affect the astrocytes. The virus can affect the astrocytes directly or indirectly, but not the neurons. So you're not getting specific neurologic deficits. You're getting more global deficits like difficulty thinking and attention, and that may be more of an aspect of the astrocytes. SARS-CoV-2 can also affect the parasites, and those surround the capillaries, causing the capillaries to constrict and get these microvascular vascular infarcts. Thromboses are certainly prominent throughout all organs due to this disease. So it only makes sense that we can see this in the brain as well. And then autoantibodies can directly attack the brain tissue. There's one preprint article which I didn't want to quote, but it proposes gray matter loss, but the number of patients is very small in that one to be able to really prove, and it's also in preprint. Characterizing our long COVID patients looking across internationally, we've got 7-month data on 6,500 patients with long COVID from 56 countries. Over 91% of patients still had symptoms at 65 weeks. So it was taking a long time for people to be able to recover from this. The most common symptoms are fatigue, post-exertional malaise, and the cognitive dysfunction of brain fog that I described. 85% of patients had relapses that were mostly triggered by exercise. And this is something that you very commonly hear, is that patients may have a good day and go out and they may try to return to their normal level of activity, but then they end up paying for it over the next couple of days. 1,700 respondents, or 45%, had needed to reduce their work schedule compared to their pre-illness work abilities. And 22% were not working at the time because of their persistent illnesses. The cognitive dysfunction was common across all age groups, and we're finding that in about 88% of patients. So when we look at this slide, as you can see, the different colors represent the different age groups, and all cognitive issues were seen in a lot of folks, 70% and greater across all age groups. As we think of attention and thinking and executive functioning, those are the main symptoms that patients are finding. So one of the questions is, why are we seeing that less in those that are 70 and above? And one thought is that as we age, if we start to forget things, have a little bit less attention, we might be less likely to relate it to the COVID infection and might relate it more to just our aging process. So some of this might be self-report of patients thinking, maybe it's just because I'm getting old. All of this really does have an impact on the patients and their lives, and then as a result, society, because we can see that when we talk about work, these folks, about 85%, almost 88%, were unable to feel like they could return to work, having a lot of difficulty making serious decisions, a lot of difficulty driving. And even when we're about 50% of them, a little less than 50%, are even having difficulty watching their children or cooking hot items. So these are things that are just your daily life activities that are really being significantly impaired even 6 months later. Data just came out recently in the Lancet from the China cohort as well, looking at 1 year outcomes. So we're talking about people who are surviving with persistent symptoms an entire year later after their COVID disease. And having looked at over 1,200 patients who'd been hospitalized, so these patients were initially sicker. But if you look at the 12-month data, 50% had at least one of the following symptoms. The most persistent symptoms were fatigue and muscle weakness, sleeping difficulties, hair loss, the smell disorder, but palpitations and joint pain. So 50%, that's a tremendously large amount of patients who are still suffering from this disease long afterwards. So, is long COVID due to persistent clotting? We don't know the answer to that, but at least one study in cardiovascular diabetology that just came out about a month ago, looked at 13 blood samples from healthy volunteers, 15 from those undergoing acute COVID infection, 10 with type 2 diabetes, and 11 with long COVID. And what they found was that the long COVID patients, their plasma still had large amyloid deposits or microclots compared to the controls and the type 2 diabetics. The microclots were also seen in those undergoing COVID and long COVID, and these microclots seemed to be resistant to fibrinolysis, even after there was trypsinization. There was also a substantial increase in the alpha-2 antiplasmin, various fibrinogen change, as well as serum amyloid A. And these were trapped in the solubilized fibrinolytic resistant pellet deposits. So this is at least some early information that's leading us to think that they may still be having problems with clotting well after the initial infection is gone. Helen Fogarty has recently postulated that a persistent endotheliopathy may be the pathogenesis of the long COVID syndrome in looking at 50 patients, meeting the definition, 68 days post-COVID. And what they found is that there was ongoing endotheliopathy in the patients independent of the acute phase response. We're so used to seeing an elevated CRP and ferritins, but she was looking at plasma factor 8C levels, thrombin generation, all of that was increased, as well as some of the von Willebrand factor levels as well. And these all remained persistently elevated in a significant proportion of patients. So she also found that the markers of this endotheliopathy, when they were elevated, they corresponded with the clinical findings that the higher the markers, the lower patients were able to complete a 6-minute walk test. So it really did seem to go along inversely with their symptoms. So why are we talking about this today even? It's certainly an issue, but this is having a huge impact on so many patients across the world. I'm looking at a low ball number of 10%, although I showed you some of the studies that it may be closer to 30 or 50% of patients, but let's assume it's only 10% of patients that have long COVID. Worldwide, that means 23 million patients will be experiencing long COVID. In the United States, it's well over 4 million alone. In Ohio, where I practice, 140,000 patients. And over in the United Kingdom, just as an example, 750,000 patients. So this is going to start to overload a lot of our hospital and medical systems. When we talk specifically about a couple of certain populations with COVID, this really is seeming to affect a lot of our older patients. And why? Because when they underwent lockdown, a lot of them decreased their exercising. They weren't able to get out and go to the mall and do their routine walking, and they developed some sarcopenia. Also, as a result of the inflammatory cytokines that started to destroy some of the muscles and cause them to develop cachexia. This loss of muscle also was aggravated during immobilization during the hospitalization, and that's even worse if they were in the intensive care unit and on artificial ventilation. So when we talk about quality of life, I just want to look at the very bottom of this. So of the 57 participants who were looked at after 6 months, 35% were still impaired with their ability to perform activities of daily living. And these are patients over 60. 33% had reduced mobility. 33% were still in pain. And 43% of them felt that they were still having some cognitive function deficits compared to where they were before hospitalization. So it's really having an impactful time in our older folks. So we know that obesity is a risk factor for developing acute COVID, but some researchers here at the Cleveland Clinic have also showed that obesity may be a predisposing factor for people developing post-acute or long COVID. So they looked at over 2,800 charts looking at folks 8 months beyond their initial COVID infection. And they found that there was a 28 and a 30% higher risk in rehospitalization for those who were moderately and severely obese. And they needed about 30% of them needed a further testing and further evaluations for different medical problems. So obesity is going to be a significantly seen in our long COVID patients. Long COVID can also impact children, unfortunately, because they're going to have years potentially to live with this. The first study on long COVID showed that more than half of children between the ages of 6 and 16 who contracted the virus have at least one symptom lasting more than 120 days. And 42.6% of them are impaired by this during their daily activities. So think about it, being able to just simply go to school or play. Nearly half of the kids are being affected by that. In the United Kingdom, they also found that nearly 13% of children aged 2 to 11 and 15% of kids aged 12 to 16 had symptoms 5 weeks after their initial infection. So these numbers are really concerning, and hopefully we'll be able to get a vaccine into all of these kids soon so that they don't develop long COVID. So this was initially, some of this was initially recognized internationally by Dr. Fauci, who called a group together in December 3rd and 4th to start discussing how the federal government was going to be responding to this. The World Health Organization has already been updating its guidance and resources on long COVID. In the United Kingdom, the National Health Service has launched 40 long COVID clinics all across the UK. And here in the United States, there have been a number of long COVID clinics that are opening, with the most notable being in Mount Sinai, certainly San Francisco, Hopkins, Houston, and Yale, to be just to name a few of them. And the NIH has already granted over $300 million toward long COVID research and is planning almost $700 million more. So this is real, and it's getting attention. So here at the Cleveland Clinic, we developed a Center for COVID Recovery called the Recover Clinic, and we're looking to really start to develop some state-of-the-art diagnostic plans and some evidence-based treatment, because that's really important that we learn appropriate treatment and make sure that it's evidence-based. All of our patients that we are entering into the clinic have a positive COVID test by PCR. We want to make sure we're looking at apples and apples and not necessarily mixing this with patients who might have chronic fatigue for other reasons. We're only looking at adult patients, although, as I just mentioned, unfortunately, we're seeing this in children as well. We initially opened February 10th of 2021, and since then, we've seen over 1,000 patients. So how does this work? We enter people into the Recover Clinic and do a workup that I'm going to show you on the next slide, but then depending upon the evaluation that we find, the test results, and patients' clinical symptoms, we refer them to any number of 18 specialists. So we have people designated in each of these specialties that are becoming our long COVID experts. Baseline evaluation, as you can see, we have some testing that we're doing and procedures that we're looking at for each and every one. I won't go into details about this, but we kind of cast a wide net because these patients have a wide variety of symptoms. So it's difficult to try to come up with any one test that's going to be able to address all of our patients' needs. All of our specialists have come up with specialty care paths for our post-COVID patients. Cardiovascular care is just one example, but we have a number of different pathways for people depending upon what findings they might have. For our first 924 patients, we're seeing things a little bit more skewed toward the female, and we are seeing that initial data came out of China was looking a little bit more toward the men, but as we look to data internationally, it's a little bit more skewed toward female population. Ours is about almost 3/4. We're seeing 77% white population. Our mean age is about the same as what I'm seeing internationally as well. It's about 50. I'm wondering if the Delta virus is going to be changing that, though, as we're seeing younger people getting sicker with this. So our mean age may start to decline. As I mentioned before, we have a population that is more on the obese side with a BMI of almost 37. And only 29% of patients had been hospitalized. So again, people with a mild to moderate COVID illness still going on and experiencing symptoms months later. 87% of our patients are complaining of fatigue. We have still dyspnea on exertion, a lot of brain fog. Difficulty sleeping is something that I think is being underestimated in a lot of the literature, and we have a very active sleep study group that is looking at this. The dizziness and palpitations will often take people into the cardiovascular realm to do the workup for POTS syndrome, and that's mainly what we're finding. Only 1/3 of people are reporting new depression and new anxiety. Thankfully, we're not seeing a significant amount of PTSD in our patients. When we look at the measurements for fatigue, so it's not only that patients are complaining of fatigue, but they're actually showing this on an objective scale. They're in the 10th percentile. So of all folks in the country, their ranking is, as far as an energy scale, they're in the 10th percentile. That's pretty bad. The same thing is with the neurocognitive functioning. They're way low. They're down in the 14th percentile. So the key takeaways that I want from today is to understand that long COVID is real. Long COVID can be very debilitating, and it affects every patient quite uniquely. There is not one kind of a course that anybody is going to go through or one particular list of symptoms. The symptoms can be seen in almost every organ system. And a multimodal care is really required for recovery. So you make sure that you address each of the patient's symptoms that they're having with kind of wraparound services, including physical therapy, rehab therapy. Thank you very much for listening, and I'll answer your questions a little later.
Now I'd like to welcome a friend and colleague, Dr. Karen Joint Maddox, who's a cardiologist at Barnes Jewish Hospital and Associate Professor of Medicine at Washington University School of Medicine. She's the co-director for the Center of Health Economics and Policy at Washington University. She's a health services and health policy research with broad expertise in quality measurement, value-based and alternative payment models, and health equity. She's also the associate editor at JAMA and serves on a number of key national committees related to healthcare quality and policy. Please welcome her as she talks to us about missed and delayed cardiovascular care during the COVID-19 pandemic, consequences for population health.
Hi, my name is Karen Joint-Maddox. I'm an associate professor at Washington University in St. Louis, and I'm honored to be with you tonight to talk about missed and delayed cardiovascular care during the COVID-19 pandemic. These are my disclosures. I serve on a health policy advisory committee for Centene Corporation, which is a Medicaid managed care company, and I will not be discussing any non-FDA approved indications. So we'll start with just an overview of what we hope to cover in our brief time together, which is to say, first we'll start with, what do we know about cardiovascular outcomes during the pandemic? We'll talk about what we know about missed and delayed cardiovascular care during the pandemic. And then we'll end with some of the potential long-term consequences for cardiovascular health at the population level. So nationwide, we know that COVID has been associated with more excess deaths than those reported from COVID alone. So if you look at this graph, which is using data from CDC, MMWR, so just sort of national death reports, you can see that the top line, so the lightest blue, shows you the total deaths above average, about 300,000 at the time where this graph was made. Obviously, COVID continued on past September, but we'll look at this for now. And if you look down at the bottom, you can see the black and darker blue, and that is the total number of deaths above average and above an upper bound, so a more conservative estimate, if you actually exclude the COVID deaths. So these are additional deaths that were not from COVID, at least to the best of CDC's knowledge. Now, early in the pandemic, you could argue that perhaps we didn't know all of the deaths that were happening from COVID because of difficulties with coding and those sorts of things. But I think we'd all agree that by July and August, where you see a second bump in non-COVID related excess death, that we had a pretty good idea of who had COVID. Testing was good, capacity was good. So we really do think that there have been excess deaths related to sort of the spillover from COVID during the time period of the pandemic. We also know that many of these excess deaths were cardiovascular or cerebrovascular. So this is work led by Rishi Wadera, and you can see in the red lines on each of these panels, the numbers for 2020 compared to 2019 in the blue lines. And you can see that for ischemic heart disease in the leftmost panel, a big spike in weekly deaths per 100,000 population around the time of the initial COVID epidemic. These data don't go quite as far as the prior ones. And then in the middle panel, hypertensive diseases, and then a little bump in the cerebrovascular disease panel next to that, not nearly as much for heart failure or other circulatory disease. We also know that excess deaths were disproportionately among Black, Hispanic, and Asian groups. So here we're looking at a similar setup, except for now we've broken down each of these panels into racial groups. So you can see on the left, if we look at heart disease deaths during COVID, and this goes from March to August of 2020, the absolute monthly death rates per million are in a solid line for 2019 and a dashed line for 2020. So you can see if you look at the top two lines, that is individuals identified as Black, and you can see a big bump in April compared to the other months and actually continued excess mortality across the time period. The purple lines right below that are for white individuals in 2019 and 2020, and maybe a tiny bump, but really not much effect compared to what you can see in the Black population. And then below that in the blue lines are Hispanic individuals and the red lines are Asian individuals. And in both cases, you can see significant bumps, lower absolute event rates, but still significant bumps around the time of COVID. The panel on the right looks at the same thing except with cerebrovascular disease. The first thing, of course, to note is the just profound inequity in cerebrovascular disease outcomes for Black compared to all other groups. Again, with Black individuals represented in the green lines on the top. But again, you can see the excess mortality associated with 2020 as shown in the dotted lines for each group. And when we look at that by ratios, we can see that the relative excess risk was pretty similar across minority groups as compared to the white reference group in this case, but that the absolute differences were largest for the non-Hispanic Black group because of the much higher baseline rates of events. So you can see the risk ratio in the second column there for 2020 versus 2019. So 1.02 for white, 1.19 for Black, et cetera. Reasonably similar for Black, Asian, and Hispanic. But when you look at the absolute difference in the far right-hand column, you can see, a tenfold higher increase for Black compared to white individuals in heart disease, and about a fivefold higher increase for Black compared to white in cerebrovascular disease, because of the combination of a higher relative increase and also much, much higher baseline rates of cardiovascular disease. So the question then is why? In part so that we can prevent this in the future. We, of course, all thought that COVID would go away quite quickly, and it did not. And this may have implications for future disruptions to care or care delivery in general, even absent COVID. So what do we know about why this could happen? Well, there's at least three possibilities. The first is delays in acute presentation. So people were scared to come to the hospital. And so there may have been delays in people showing up for treatment for their cardiovascular or cerebrovascular disease. There may have been differences in acute treatment. So if someone arrived to the hospital, perhaps the cath lab took longer to be activated because of concerns about PPE or other sort of processes in the setting of the pandemic. Or there could have been disruptions to usual outpatient care. So people could have not gotten their medication refills or, not been able to access sort of the care that could have prevented the emergency visit. And each of these could have led to worse clinical outcomes. So there's not terrific data on these, but I'll go through sort of an overview of what we know and then talk a little bit about what we don't. So we know that very early on in the pandemic, rates of acute MI dropped across the country. So this is probably the first thing that came out about it in, I think, April. So it was released as a preprint. And you can see that from a number of centers around the US, a pretty significant drop in the total number of STEMI activations from, typically running in the sort of low 200s down to the mid 100s in March. And this pattern, of course, persisted, but this was really sort of the first indication that we were seeing something, I think, unexpected in terms of the magnitude of the drop in people presenting with acute MI, which one would not think would be discretionary in terms of seeking care. And interestingly, people reported about the same drop around the world. So on the left panel, you can see data from Spain. On the right panel, you can see data from Austria. And in both cases, they reported, a roughly 40% drop in individuals presenting with acute MI, suggesting that this was a really widespread phenomenon, that we saw significant drops here. Similar things were seen for stroke. You can see on this graph, again, only going through March, but chest pain, heart failure, stroke, and other cardiovascular really all dropping off pretty profoundly as COVID started to spread. And again, this has been then carried on farther out, but even in the first weeks to months, we were already starting to see a concerning drop in what, again, we would consider to be non-discretionary cardiovascular care. Now, interestingly, we did some work looking at decreases in emergency department visits, and they didn't vary much by acuity, even more broadly. So I'll sort of explain what we're looking at here. In the bar on the left, the blue bar, you can see the drop during sort of the summer of COVID, spring and summer of COVID, in non-COVID emergency department visits by classification. So the blue bar is emergency department needed, not preventable. So this would be things like heart attacks, strokes, trauma, things for which emergency care is necessary, and it really can't be prevented by having, say, an urgent care open or something like that. As you move to the right, so to the orange bar, the yellow bar, and then the green bar, you move toward things that are considered to be progressively less emergent. So these are basically using claims to classify emergency department visits. So not perfect, but certainly not categorically wrong. So the non-emergent bucket might be something like sore throat or upper respiratory infection, where really emergency department care was not perhaps the optimal way to have this condition treated. So we saw about a 40% decrease in the truly emergent non-preventable things that you would not think should have decreased really at all over the course of sort of the spring and summer of COVID, and about a 50% decrease in the things that one might have thought would decrease a lot, right? If they weren't emergent, they really should have dropped off a lot if there was concern about coming to sort of a COVID-infested ER. And interestingly, we did not see the gradient here to the degree that we thought we might. Now, of course, the consequences of those delays likely do vary by acuity. So this is internal data from our health system demonstrating that the inpatient mortality rate from the prior slide, we know that the volumes for heart failure and acute MI dropped 40 to 50%-ish. We know that mortality for heart failure was about the same comparing prior years to 2020. But for acute MI in our system, and this has been reported elsewhere as well, we saw higher mortality, particularly among the STEMI patients. Patients were coming in sicker. We were seeing more sort of complications of delay, things like rupture and things that frankly I hadn't seen in years, likely because of delayed presentation. Now, the second thing that I mentioned could have led to differences in outcomes and this sort of acceleration in cardiovascular mortality was changes in inpatient treatment. So were people less likely to receive PCI, less likely to be sent home on the right medications? Those data have been less clear, and it likely depends on the geography. So on the left, you can see some data from Turkey. On the right, again, our system data. And you can see that they saw a decrease in individuals undergoing PCI for non-STEMI and for STEMI, although it was less for STEMI, suggesting that in truly urgent cases, most patients were still getting the care that they needed. We didn't see any decrease for STEMI and only a very small, not significant decrease for non-STEMI here. We were never really overwhelmed by COVID just because of the way that it sort of rolled into the Midwest. So the data that we do have on inpatient treatment is much more patchy across the country, whereas the drops in the sort of presentation and the rises in mortality have been sort of pretty stable across the country, actually, regardless of the burden of COVID. So suggesting that really the presentation is playing a bigger role than actual changes in inpatient treatment. So what about outpatient care? Well, we know that there were huge disruptions to usual outpatient care, right? And you can see here in some data from Optum that outpatient visits dropped, and this is weekly visits per 1,000 members on the y-axis. You can see sort of, moving along relatively stable along the weeks in 2020, and then dropped precipitously around the time of COVID, rebounded a bit, and you can see in the blue bars or the blue circles are in-person visits, and then telemedicine starts up. Certainly in our system, we went from saying telemedicine will eventually happen to we will have telemedicine tomorrow, based on the need to try to fill some of this gap. And so you can see telemedicine growing significantly between weeks, say 11 and 15 or 16 in 2020. But the total visit in those tan diamonds never got all the way back up to usual outpatient care. Even later in the year, most emergency departments nationwide were still running about 10% under their usual volume. Many clinics were running at least that under their usual volume. And so we know that telemedicine didn't fully fill the gap and that there was still foregone care and disrupted care on the outpatient side. Now, one interesting recent study tried to get at what the consequences of these substitutions might be. And so this is a study that looked at cardiology telehealth visits. And you can see here, looking across 2020, this now goes all the way out to December, looking at April, you see in-person video and telephone visits very low. And then moving out across the later months, you start to see the in-person visits picking back up in the sort of dark blue, video visits in the light blue, and then telephone visits in the orange. over the course of the rest of 2020. And you can see that the odds of ordering any medication were significantly lower. So the odds are on the y-axis, and you can see the odds of ordering a medication during a visit were much lower for individuals being seen by telephone or video in the orange or the blue compared to in person, particularly later, as there was more sort of telemedicine happening, of course. And you can see similarly odds of ordering any test. So the odds for the telephone, all the way on the bottom in orange, remain the lowest. Video a little bit higher than that in the blue, and then in person up close to 1 compared to prior years. But overall, suggesting that less was being done in terms of prescription and testing, particularly among those people who are receiving telephone visits. Now, one reason this is particularly important is because we know that some of the people who elected telephone visits as opposed to in-person were potentially groups where we have seen inequities previously. So women more likely than men, and Black and Hispanic patients more likely as well to have elected a telephone visit during COVID. And so if we have existing inequities in who's receiving, say medication titration or monitoring or prescription of new medications, we could see those inequities reinforced or broadened even as a result of the diffusion of these technologies in a way that is not entirely equitable. Now, of course, the population health effects are yet to be seen. It's just too soon to know exactly what the effect of this third wave is going to be. The first wave we had hoped would come and go. It has obviously persisted a little longer. The second wave of deferred and delayed urgent care, I think we have seen in the acute MI data. The third wave of interrupted outpatient cardiovascular and sort of general preventive care is where the story is still being written. So what are we doing right now? What is our proactive outreach? Are we making sure patients are getting their refills? Have we been using population health management tools to see if there are deviations in blood pressure or blood sugar control? Have we been sending out screening reminders for lipids, blood pressure, and cancers? And in maybe previous years, we would assume people would show up to clinic and we could just order those things then. But if we don't have clinic, what are we doing proactively to make sure that this third wave is not going to lead to bad long-term cardiovascular outcomes for our patients? We know that practices and systems probably differ quite a bit in their current approach. There are some places that are very population health oriented, more of a medical home or accountable care sort of model, where some of these things may be done anyways, even in the absence of a global pandemic. But many places are not set up to work this way, and not set up to say, if I have my panel of patients, how am I managing their health, not dependent on when they show up to clinic. And so I think it will be extremely important to study how these different practice patterns and interventions can either protect our patients against or leave them vulnerable to the impact of care disruption for their cardiovascular health. So to sum up some key points, COVID led to missed and delayed cardiovascular care, both acute and chronic. There are significant gaps in our knowledge of both the incidence and the consequences of this missed and delayed care, particularly in what the long-term effects may be. I think there are significant lessons we can learn, both for cardiovascular disease care in general. We could probably suss out something about how we should be caring for patients proactively. And also, I think for health equity, we know that COVID had a profoundly inequitable impact on our most vulnerable patients, and understanding the effects for cardiovascular disease as well as for COVID itself may help us find ways to potentially reduce those inequities in the future. I'd like to thank you all for your attention and very much look forward to any questions and comments. Thank you.
Now I'd like to welcome Dr. Cassandra Pierre. She's the assistant professor at the Boston University School of Medicine and medical director of public health programs, as well as associate hospital epidemiologist at Boston Medical Center. She also chairs the Diversity and Inclusion Council. Her research is focused on infection prevention in vulnerable populations, and she has clinical interests in HIV management in a number of special subpopulations. Please welcome her as she's going to illuminate us on healthcare disparities exposed, how COVID-19 showed us that we need to do better.
Hello, it is wonderful to be here with you today. We know that federal, local, and state data continue to show us that there are significant disparities in COVID-19 cases and deaths in Black, Brown, Indigenous populations, and those who are systemically marginalized. The magnitude of these disparities have been shocking for some, but have actually provided a large spotlight on underlying social and economic inequities that have driven health disparities for centuries and will continue to do so until we are able to learn from them and promote sustainable and durable changes in policy. I have no disclosures to make, and I will not be discussing any non-FDA approved indications, but I will be focusing on COVID-19 outcomes by race and ethnicity. And we know that the outcomes that we're seeing are not due to biological determinism. So I'll walk us through the historical and current policies and practices that have been marginalizing, experienced as racist, that have led to these health outcomes, and then discuss how to recognize and begin to address health inequities. So just to jump right into it, we are now in November 2021, so 20 months into the thick of this pandemic for most of us. And we continue to see that cumulative data shows us that Latinx and Native Americans continue to experience higher numbers of cases, 1.7 to 1.9 times higher number of cases than white people, and that American Indian, Black, and Latinx populations continue to experience higher levels of hospitalization and death than white populations. When we look a little closer about how people are getting tested and how they're experiencing healthcare access, we see that the inequities in race, ethnicity, and even location cannot be dismissed. So, for example, a study that was published last year looked at zip code tabulation areas in 3 metropolitan areas, specifically New York City, Philadelphia, and Chicago, and saw that the zip code tabulation areas that correspond to neighborhoods where there were a majority of Black and Latinx individuals had lower testing rates but higher COVID-19 positivity rates than white neighborhoods. And in addition to this disparity in low testing access but high COVID positivity, we also saw that there were less access to hospital beds in those same Black and Latinx neighborhoods. So prior to the pandemic, in New York City neighborhoods that were predominantly Black and Hispanic, there were about 8, on average, hospital beds per 1,000 residents. And after the pandemic, that did grow a bit in April 2020 to 10 hospital beds. But that increase was nowhere near that seen in white neighborhoods, where the average number of hospital beds per 1,000 residents went from about 70 to 75.5. So we can see that we're actually widening the disparities of care. And this is despite, once again, these communities experiencing a higher COVID positivity than the white neighborhoods. We also see that critical care access is lower in those neighborhoods, with an average 0.4 hospital beds, ICU beds for the Black neighborhoods, Black and Latinx neighborhoods, and 4.4 hospital beds in the white neighborhoods. And so this is not just about testing or hospital access. We know that the downstream consequences of this will also be that there are disparities in treatment for COVID-19. There will be less remdesivir, less dexamethasone, less IL-6 inhibitors or anticoagulants. And this partially accounts for some of the disparities we see in outcomes in our structurally minoritized communities. COVID-19 has also disproportionately impacted communities of color when it comes to life expectancy. Now, to be certain, we have seen worldwide a decline in life expectancy, unfortunately, because of COVID-19 and the pandemic. And in the United States, we have seen on average a loss of 1.13 years. But this is intensified and larger in populations of color. So for Black and Latinx individuals, we see a loss of 2 to 3 years as a consequence of the pandemic. And this is on a backdrop, at least for Black populations, of already lowered life expectancy compared to the general population. So again, structurally minoritized communities are falling further behind as a consequence of some of the systemic inequities that we'll discuss in the next few slides. These systemic inequities leading to healthcare outcomes that are disparate are not new. They are the product of centuries of intentional systemic policies. And in fact, numerous studies have shown that Black and Indigenous people of color receive a lower quality of care than whites, even when they have the same health insurance or ability to pay. And this is across a number of domains. Really take your pick, whether it's maternal mortality, or cancer, or pain management. We see disparities of care in Black, Brown, and Indigenous communities when compared to whites. Now, this difference has a number of underlying causes, including healthcare system organization and operation. For example, lack of public health insurance, lack of coverage for certain diagnoses that are more common in people of color, and lack of access to facilities among them, as we've already heard. We also cannot discount healthcare provider biases, prejudices, and uncertainty when treating minoritized communities. For example, stereotypes about whether Black people feel the same level of pain, inappropriate or ineffective communication styles. And many of these biases are subconscious. The factor that I'd really like to focus on, however, for the remainder of our time together would be social determinants of care, which encompass inequities that discourage patient adherence to medical advice and contribute to distrust and mistrust. Now, these social determinants of health encompass the conditions in which people are born, grow, live, work, and age. They include things like social and economic factors, health behaviors, and the physical environment. These are shaped by the distribution of money, power, and other resources throughout communities, the nation, and the world. And differences in social determinants of health lead to health inequities. In fact, 80% of health status is attributable to social determinants of health. And this doesn't mean that quality health care is not important. In fact, it is critical, but alone it cannot help or hope to achieve changes in disparities that we're seeing unless we have concurrent changes in the systemic inequities and policies that have led to the disproportionate or maldistribution of access to these social determinants of health. In addition to the systemic racism that we've discussed, the social determinants of health have real and tangible impacts on health and length of life. So how does systemic racism, or the legacy of this racism, tangibly affect access to social determinants and therefore health outcomes? Well, I'll give you one example, and that is the experience of redlining. Redlining originated in the 1930s and was a government bureau initiative to color code neighborhoods in cities based on financial risk. In effect, it determined a neighborhood's eligibility to receive a loan or a mortgage, essentially to be invested in. What happened was that the lowest ranked neighborhoods were outlined in red and usually denoted Black or Latinx communities, regardless of socioeconomic status. So by default, being in a Black or Latinx predominant neighborhood meant that you were redlined because you were deemed to be a higher financial risk, whether that was true or not. These maps were then used by banks and loan offices to determine who was eligible for incentives in their neighborhoods and used to directly discriminate and provide refusal for loans to residents of those red-lined neighborhoods. So you can imagine, you could be living in a beautiful home that you've saved for, and the banks refuse to give you a loan to repair windows or insulate your house or remove asbestos. And eventually that home falls into disrepair in addition to the homes of your neighbors, and that neighborhood then becomes blighted. The rules of redlining apply equally to companies and stores, and so the residents of these redlined areas lost access to quality housing, to good grocery stores, to quality education, to healthcare access. And this basically formed a locus, an engine for disincentivization and disparate health outcomes. The outcome of this more tangibly includes erosion of community resilience and wealth generation, or the ability to generate wealth through systemic disinvestment. Redlining was associated with declining in impoverished areas that led to food insecurity, lack of transportation, inferior educational and healthcare resources, and substandard housing. And the effects on health are, I would say, legion. There are many, many articles, even today, talking about the effect of redlining on health impact, even though redlining was outlawed in the 1970s. We see a higher rate of childhood asthma, for example, higher incidences of chronic disease, including COPD, diabetes, hypertension, high cholesterol, kidney disease, and obesity, higher rates of cancer. The list goes on and on. Perhaps most strikingly, we see a direct impact on life expectancy, where socially vulnerable populations experience a lower life expectancy than the general population. A local representation of that would be right here in Boston, where I'm speaking to you from. The residents of Roxbury, as of a 2016 survey, have an average life expectancy of 59 compared to the residents of Back Bay, who have an average life expectancy of 90 years of age. That is an over 30-year difference. It is quite striking, but emblematic of what we see when we look at differences in life expectancy across redlined neighborhoods and compare them to non-redlined neighborhoods. More specifically for our discussion, redlining has also caused COVID-19 hotspots. So the areas with greater social vulnerability that were analyzed during the first and second waves of COVID-19 in our country were noted to be more likely to become areas with rapidly increasing COVID-19 incidences. And this COVID-19 hotspot effect was stronger in counties with red-line neighborhoods with a higher percentage of Black and Brown residents. So how can we recognize these disparate health outcomes, regardless of whether they're COVID-19 or not, and address them? I think the first thing that we need to do is know where we are starting from. Disaggregation of outcomes by sex, race, ethnicity, age, housing, insurance, and other markers of marginalization are incredibly important, and many healthcare systems are beginning to do that. For example, in my institution, Boston Medical Center, we've looked at a host of very high priority health outcomes and looked at our performance based on race and ethnicity. Now, despite the fact that we pride ourselves on our ability to care and provide excellent quality care for systemically marginalized populations, we saw significant and profound disparities across race and ethnicity for a number of health indicators, including maternal health. And so we plan to address these. The other important thing to think about when beginning to recognize and address these racial disparities is, in addition to looking at your own house, your own institution, thinking about how social determinants of health may play a role in the disparate outcomes. Improving access to preventive health care with trusted providers, including increasing the representative population, bringing in more providers, more front desk staff, more trusted voices that look like the community you're serving would be incredibly important. And then finally, moving to a proactive approach to anticipate barriers to care with creating new programs to make sure that communities have lower access to social determinants of health are able to access those resources equitably. One specific area to key in on is determining what barriers to care are most relevant to disease prevention or mitigation to the populations that are most impacted. So one example of this would be a survey released by the Kaiser Family Foundation that looked at concerns for COVID-19 vaccination for unvaccinated children aged 12 to 27 by race and ethnicity. And not surprisingly, as you might expect, Black and Latinx parents had a bit more misgiving about vaccinating their children when compared to white parents. But what you might not expect is the domains that caused them the most concern and varied the most from white parents. So if you look at the highlighted box, what you can see is the responses that most varied between the Latinx Black parents and the white parents included concerns about needing to take time off from work to get kids vaccinated, inability to getting children vaccinated in a place that is trusted, concerns about having to pay out of pocket for children's vaccines, and difficulty in traveling to a place where they could get their kids vaccinated. So these are all, again, social determinants of health, concerns about the economic ramifications or the trust ramifications. These are all concerns that are really deeply rooted in barriers to care and the social determinants of health. Another example that I could give that, again, is COVID specific is thinking about delivering health messages that are relevant to structurally vulnerable communities. So at the beginning of the pandemic, the call to action that was used time and time again within public health messaging was testing, tracing, and isolating. Today, vaccination would be at the top of that list. But some things that were potentially not anticipated when this message went out is how it would be received by structurally vulnerable communities, including Black and Brown communities. So thinking about testing, we've already talked about how communities of color had less testing access. Is the testing site that you're talking about convenient and easily accessible? Will there be transportation? And is there appropriate messaging on the indications for which people should get tested for? I think we can think about a lot of the concerns people would have with the tracing. For example, do the contact tracers live in the community and know some of the concerns and barriers of the people they're calling? Do they actually speak the same language and can they communicate effectively with the population that they're engaging with? Are there appropriate messages tailored to a population who already has a high degree of distrust from the government? We think about isolation, and the fact that many of our population, especially in socially vulnerable areas, live in densely crowded areas where they may be working disproportionately as frontline workers. Will there be accommodations made for individuals who are living in crowded multi-family dwellings who need to either isolate or quarantine? And will there be adequate incentivization for workers to compensate for lost work opportunity? For example, enforcing that employers pay sick leave. These are the kinds of concerns that need to be addressed when thinking about public health or medical messaging. So in addition to developing these messages, developing in a way that's both culturally consistent and anticipates some of the barriers would be most beneficial in supporting people in doing the right thing to care for their communities. One example of that culturally consistent and supportive messaging would be a campaign that went on in Alberta that accompanied messages of self-isolation with a mechanism to get financial support during that period of isolation where people may not be able to make money or have the resources to even pay for a hotel room to move out of multi-generational dwellings. So in summary, Black, Latinx, and Indigenous populations are disproportionately affected by COVID-19. The drivers of this disparity are not biological susceptibility or socioeconomic status, but are due to a confluence and interaction between structural racism, socioeconomic status, and social determinants of health. Resolving these barriers to health will require addressing the root causes and advocating for equitable and systemic interventions. Thank you so much for your time and look forward to your questions.
We've gotten some great questions. I'd like to take sort of organizer's privilege and ask a question to Dr. Pierre to start us off. It was a fantastic talk, and one of the things that we've noticed, and I wanted to get your thoughts on this, we have two trials that we've been doing. One of them's focused on prevention of blood clots in COVID in patients who are outpatient and have COVID-19, and the others on sort of long-term prevention of blood clots in patients with an initial provoked event. And we have traditionally at the Brigham had trouble enrolling patients from our neighboring Black and Latinx communities. But for these two trials, we've gotten just a incredible amount of support from those communities. And I was wondering what your thoughts are on whether the pandemic's changed something and what we should be learning from that so we can keep really developing this relationship that we've developed now with our communities where we're they feel welcome to participate in these studies.
I think that's a great question. Thank you for asking it. And kudos also for measuring and monitoring the enrollment in your studies. I don't want to say guarantee 100%, but my guess is that this did not happen passively. I do know that Brigham, like Boston Medical Center and many of the institutions around the country this year, have taken an active interest or more of an interest and initiative in enrolling equitably across research studies for clinical programs and trials. And I know that there is an amazing community advisory board at Brigham, as we are trying to assemble at Boston Medical Center, that have done a great deal of work this year in reaching out to community, engaging with them, thinking of ways to ensure that their time is acknowledged, rewarded, and that people see themselves present and represented in research and see the reason and connection. So that happens in primary care offices, that happens in hospitals, but it also happens in schools and in community organizations and by referral. So I do think that this is not an accident. It absolutely is true that more communities of color are seeing themselves as affected, at risk, and therefore needing to seek out prevention, treatment, and monitoring. But I think there also is a great deal of work that needs to be done and put into ensuring that these communities that have been disenfranchised, that may lack health insurance to even hear about these research trials, are being outreached to, engaged with. And that engagement also occurs with people that look like themselves, that have lived experience that is shared, that can talk to them about the importance of this research. Thank you for that question.
Excellent. Thank you so much for the thoughtful response. This is a question that I think goes to Dr. Libby. You really did a wonderful job sort of outlining the challenge that we have, especially in COVID research, where there's such a rush to find treatments, and yet at the same time, the initial studies may not be ultimately shown to be correct. How do we balance that? How do we, is there a way that either through funding or through, our own sort of control of what research happens at our centers, that we can participate in making sure that we're encouraging the best trials, not 10 of the sort of okay trials?
Well, we need to have a Challenger Disaster Commission to look at how we can do better next time. This is a wake-up call that we need to organize. I made the point that instead of 7,000 studies, we should have 700, maybe even 70 really rigorous trials. The public is looking askance at our community. They don't know what to believe. There's already distrust of science and medicine. We certainly just heard about it in certain quarters, that it is really exacerbated. We need to gain, to earn, to deserve the public trust. So we need to get ourselves aligned the next time that a health crisis hits, so that we are organized to coordinate together. I would love to see it done transnationally in a very coordinated way, to design and execute rapidly rigorous trials that are placebo-controlled, that are double-blind, and that will answer the questions. We got in terrible trouble because of our messaging that just fed into all the narratives of distrust of medicine and science. We need to earn and deserve the public trust. And so let's organize ourselves better next time.
Yeah, I think, it highlights sort of like what we've seen from some of the NIH studies that were well-meaning but came out sort of later in the pandemic after a lot of these other studies have been launched. It would have been probably in the spirit of doing 70 excellent trials, not 700 okay trials, to have thought about combining these studies and efforts together earlier rather than, it seemed like we just got off the block a little late for some of these prophylaxis trials, for example.
So maybe with Rob Califf, if he is confirmed, again, as the Commissioner of Food and Drug, we would have an ally for really waving the banner for rigorous clinical trials. He wrote that very prescient piece about teachable moment. This is a teachable moment, and we've got to learn the lesson, or we will lose more trust with the public.
I think, and that's a key point. We have lost. It's amazing how quick we lost trust that we built over, many decades. Good. Thank you. Here's a question. So there are a couple of long COVID questions that we want to dive into. One in particular I'm going to go to now because it's very interesting. From my research standpoint, focused on thrombosis. But is there any sense about the risk of arterial or venous thrombosis in patients with long COVID or long COVID syndromes? Do we know if they're more predisposed to these thrombotic complications?
At this point in time, there's not a lot of data on larger groups of long COVID patients and their the particular details and their risk factors. We're more getting descriptive studies at this point in time about epidemiology as opposed to their underlying health problems. In looking at the health risks of folks who are coming into our long COVID clinic, now granted it was like 924 patients, so not a large number particularly, we look to see who had underlying different disease processes. And really it was more of the standard kind of diabetics, patients who had underlying heart disease, the morbidly obese, which certainly one would think about the clotting risks that those patients in general might have. We tried to look to see if there was a preponderance of patients who might have other rheumatologic disorders, lupus and others underlying, and weren't seeing that. So again, our numbers are small at this point in time, but I'm not finding any particular group in particular that stands out as far as thromboses go.
Okay, excellent. And one question that also came up was about sort of heart rate variability training and whether that's something that could be beneficial, whether you've looked at it and found it to be helpful or whether it's something that's being looked at.
Yeah. So we haven't specifically looked at the heart rate variability. I know our physical therapy team is working specifically with patients who have this kind of sense of breathlessness, mm-hmm. and trying to work with them as far as monitoring their breathing as they're doing some exercising. So that is certainly a form of heart rate variability. Our cardiologists have looked into the opportunity to use a heart rate monitor on patients. So we're looking into that right now. I think it's going to be very, very important, but I don't have data for you at this point in time. But I certainly like that idea, and it would address a lot of the symptoms that some of these patients are having.
Are any groups looking at sort of different types of cardiopulmonary rehab to try to recover?
Yeah, I think virtually every long COVID program has noted at least some sort of both cardiac rehab, pulmonary rehab, and then even just working through our physical therapy group, the rehab that they're able to do. Most of the long COVID groups that I've looked into have pretty robust cardiopulmonary rehab programs.
Excellent. One last sort of question was focused on downregulation of the ACE receptor and whether that makes ACE inhibitors less effective in patients.
don't know the answer to that one.
I figured that.
I figured that would be a great thing to study and to know about. I know certainly when we initially heard about the ACE receptors, and I was on the phone with one of my family members saying, "Stop your ACE inhibitor." I wasn't sure which way to go with it, and
Right.
I don't know that question has been fully answered. But I've not heard the warning sign to either stop ACE inhibitors or to start folks on it. But I'd be curious to hear what other panelists' thoughts are on that.
Let me jump in. So the initial concern came from animal studies that showed that inhibition of ACE1 might increase the expression of ACE2. And that led people we all got telephone calls, right? And the higher socioeconomic and educational status of our patients, the more telephone calls we got about whether they should continue their ACE inhibitors or ARBs. And the answer is overwhelmingly they should continue. There were small studies, but then there were really large studies from UK, from Italy, and it is a hazard to public health to stop your antihypertensive medications that target the RAAS when they're indicated. There's evidence, if anything, for benefit and no credible evidence for harm. So I would take a very strong stance in favor of continuing the ACEs and ARBs in our patients who need them.
Excellent. Here's a question for Karen. Karen, your talk was fantastic, and it's like you said, we noticed this, and now our hospitals are seeing the sequelae of sort of patients who didn't come earlier in the pandemic, and we're bursting at the seams with patients that need care. How do we do better next time? From a public health standpoint, from a messaging standpoint, how do we make sure this doesn't happen again?
I think there's two answers to that question. And it's a great one. The first is, as you mentioned, the public health messaging, which is to say that certainly, initially it wasn't safe to go to the emergency department, so it would not have been responsible for us to encourage people to do so. But, fairly quickly, we got some of the PPE issues figured out, and we needed to do a better job than we did of reassuring people, being very clear, we're putting patients over here who we're suspicious about, or, whatever you were doing. We needed to be more explicit about how we were protecting people in the hospital because people would not come. I think the other thing that we need to think about is what this tells us about our broader healthcare system and how we manage our cardiovascular patients in general, which is that we sort of leave them out in the breeze to do as they will. Healthcare is too complicated for that, and chronic disease management is too tough for that, and particularly for our older patients, for more vulnerable patients, we need to think more about our role as cardiovascular specialists and really a medical home sort of approach, where we do proactive population health, and we think about people as our people, right? People that we want to help them make it through whatever the challenge is, be that a pandemic, be that a death in the family, whatever it is that sort of shakes up your world where you need support. We have a role in that. I hope this makes people think a little more proactively about population health. I think we're a long way from it for a host of policy reasons we can talk about another time. But I think both public health and from our own sort of medical management, we need to do better.
Do you think that, because we've certainly developed a lot of skills in telehealth and in virtual visits, and yet we didn't seem to curb this, what we're seeing now. We didn't, whatever questions we thought we were answering, we didn't, because now they're all coming to roost again. Is there a way to use that going forward, that we can use it better in a better way to prevent this from happening?
Yeah, I think actually Dr. Levy referred to this in his talk, which is to say that telehealth is not a substitute for in-person visits. What it may help us do is the things that we don't do well in in-person visits, though, right? The check-ins. And I think there's a way to take what we've learned from telehealth to think about how we can augment our management and be better by using telehealth, by thinking about it as an add-on as opposed to a substitute. And, what does the patient need? And then figure out in our armamentarium of things we can deliver, where does it fall in the telehealth to in-person visit spectrum? And I think there's probably a lot of ripple effects, I hope, as we think about how to do this better across cardiovascular disease.
Sure. Excellent. And a question for Dr. Stevenson. vaccine hesitancy is something that really has, it's been ever present since the first wave of vaccinations about a year ago to now with children. Some of it has to do with the politicization of vaccines and sort of the pandemic, but some of it has to do with the fact that we haven't done as much as we could have done to garner the trust of the American people in the process of developing these vaccines, in the process of testing and studying them, and in the process of rolling them out. How can we repair that? In your view, as someone who studies these vaccines, what could we do differently, not just for the future, but even now, where we still need to get much greater uptake of vaccines?
Well, I think the first thing is to acknowledge that vaccine hesitancy is not new, and hesitancy to be experimented on is not new, and hesitancy to accept blankly recommendations from authorities or federal governments is also not new. So what it revealed is that as a scientific community, we really hadn't learned anything over the past 50 years in terms of like consistently failures, right? So we have not engaged communities that we should have been engaging with for decades. So what happened with us, I mean, I know the Brigham had this experience as well, is that we're like, oh my gosh, this is so disproportionately affecting, Black and Latinx communities. Like, let's make 1,000 flyers and go into Dorchester and drum up the interest, and it was ridiculous. And everybody there said, what are you talking about? Like, why do you care now? Like, I didn't see you 2 months ago. So I think that was a lot, and it's embarrassing, right, for us to have to learn this stuff that's so basic. So a lot of what I try to encourage people to think about is that people who are hesitant to get vaccinated or declining vaccination is not one whole big homogenous group of people. It's an extremely diverse and heterogeneous group of people with many, many, many different reasons. And I think we can sometimes fall into the trap of being pretty judgmental because we all kind of see so clearly the vaccine benefits are so unbelievable, but we really need to listen more than talk. So we have to understand where people are coming from, and sometimes you won't be able to move them at all because it is very polarized or it has something to do with a very extreme worldview. But in a lot of cases, that's not the case. And you can also, it doesn't all have to happen at once. So we also are trying to say, like, look, we're not going to necessarily convince this group right here today, but we're going to build a bond, show we care, come back, do a second town hall, maybe even a third town hall, and let's slowly start to get people to just to trust and to believe that we care. So I think that, I really encourage people, if we're going to make any dent in getting to these pockets of people who still aren't vaccinated, is to put a little bit of our snobbery aside, listen. Maybe I'm not the right person to do it. Maybe it's a person who looks different than me or has a different background than me should be the one doing it, and just really try to be patient.
Excellent. I'd love to give our president, Dr. Goldhaber, the chance to ask a question or questions.
Okay. Well, what a spectacular symposium. I think we've all learned so much tonight. I'll tell you, at Brigham and Women's Hospital, there's a phenomenon going on, and actually throughout Boston, that we really don't understand. And I thought if anyone could explain this to us, it would be Karen. Our hospitals, the past 7 weeks or so, have run a census of between 105 and 108% without let up. We are shedding each night about 45 admitted patients in the emergency department and another 15 or 20 in the post-op recovery area. And we don't really understand why. our COVID numbers, because of the high vaccination rate in Massachusetts, have not been very high. We've had between 15 and 20 patients in the hospital at any one particular time, and some of those are referral patients on ECMO or who need lung transplants. It just seems too far from the surges that we had to really make much sense of it. So do you have any explanation, Karen?
I think we deferred a lot of care that was only deferrable in the very acute sense. So we deferred anything elective, which could have been bypass surgery, right? I mean, we tried to get in our patients who had some of those needs, but we deferred things that were not indefinitely deferrable. And that's really coming back, I think, to fill up our hospitals. We're seeing the same thing. The other interesting thing that we've seen is that if you look at death among very death-prone people, so frail individuals in long-term care, death rates were very high initially in COVID and are actually lower now, right? Because there's sort of a survival of the fittest sort of effect. And so while there was a lot of early death in very sick patients, a lot of people are now just hanging around who remain quite chronically ill and now have all those needs to be met. So we are seeing exactly the same thing here. And I suspect we'll be dealing with it through, at least the middle of next year, off and on, as we sort of see the ripples of these deferred care episodes.
Interesting. And I just have one more question, really, about the long haul COVID syndrome. I am really evaluating most of the patients who come to cardiology for this problem. Our program at the Brigham is run by the pulmonary division, so they will farm out consults to the different subspecialties. And I've noticed a couple of things I'm wondering if the panel has as well. One of them is most of the patients I've evaluated had mild cases, as was mentioned, but had been before COVID athletes, marathon runners or 10K runners, super conscious about their health, and just come in disabled from long haul syndrome. And we would run a battery of tests, including cardiac MR, and most of the time, those tests came back normal. And so I'm wondering, but actually, any of you who deal with this, think about it.
Well, I'll start, at least from our experience here. No, I agree with you. I think the folks that we're seeing are probably people that were the most active before COVID, and they're seeing a great difference. For those people who may have been debilitated beforehand, they may notice it less. As I was saying with the brain fog, in our 70, 80-year-olds, if they have a little bit more brain fog, they may be saying, I'm another year older, and not recognize it as being such a difference than if we take somebody who is a high-functioning athlete or somebody who's a CEO and is suddenly starting to notice that they're not running that distance, or they're not managing their books like they used to. So I do think that we see the biggest difference in our highest functioning people beforehand. And I agree, it's so hard. We started throwing out this big net trying to look, because when patients present with fatigue, there are so many different causes of what fatigue can be. I mean, are they not sleeping well? And that's why they're fatigued throughout the day. And our sleep groups are actively really looking at this, because that is a significant problem for our patients. How do you tease out the depression? How do you tease out any residual? I'm not seeing as many people, unless they were hospitalized and had clear pulmonary issues initially. We're not seeing persistent hypoxemia in these folks. So I'm not surprised that you're not finding an awful lot of hard data on this. And yet you talk to these patients and it is real. So I think that's where the frustration is, not only for the patients, but for us trying to find the best ways to care for them, is what's really at the base of this. And we've got a long way to go looking at that.
Yeah, well, I like your talk of this as the second pandemic, because I think the emotional, psychiatric, economic, and social consequences will be long-lasting and profound.
I want to thank the faculty for just being spectacular in taking very complex messages and bringing them home in a way that I think, will stimulate us going forward, but also push us to try to do things a bit better.